Dr. Javed Ahmed from UK, Dr. Afsar Raza from UK, Dr. Imad Shehban, Dr. Abdus Samad, Dr. Khabar Kazmi, Dr. Tariq Ashraf, Dr. Khalda Sumro, Dr. Umar Rana, Dr. Mozam Naqvi, Dr. Rehan Riaz, and Dr. Muhammad Kashif Sheikh. So, over to Professor Ramesh Daggubati. Can you please share your slides with us?
Yeah, I'm sharing my screen. Can you see my screen now?
Yes, okay. Ramesh, we can hear you, and we can see you, and we can see your slides also, so please go ahead.
Okay, thank you very much. I would appreciate if everyone else can mute their phones. So this is a great pleasure to be with you all. Unfortunately, I'm not there in person, but I know my heart is over there. And thanks to Bashir and all of organizers of Pakistan Live 2023. So without further ado, I'll go ahead with my talk on best strategy to trim the rock and tips and tricks. I don't have any disclosures. As you see that this is a letter that was published back in February 4th, 1978, a letter to the editor. The second PCI that was done by Gruntzig was actually a calcified lesion that was not successful with a 70% in the left coronary artery. And the patterns of calcification in the coronary artery disease can vary. If you just look at angiographic, only about 38% of them are calcified, it appears. But if you use intravascular ultrasound, about 73% of them are calcified lesions. So we underdiagnose calcium in the coronary arteries. And of course, the calcium is a poor predictor of all major adverse cardiac events, including death, MI, as well as any revascularization, is much higher in the red bars, which is severely calcified vessels, versus not so calcified vessels in the blue bars. So the complications are the vessel is prone to dissection during balloon angioplasty aggressively or predilatation, and lesion is difficult to completely dilate. Inadequate stent expansion is what we call as rotor regret, and can prevent stent delivery to the desired location. And uneven drug distribution is associated with the restenosis as well. So how do we approach? I think this is going to be dealt in greater detail later on. Whether balloon crossability, yes or no. And this is a simplified version. That's what I like actually doing as well. If I can pass a balloon, then I do an IVUS to evaluate how much of the calcium, and if it is superficial or a deep calcium. If it is deep calcium, go with the lithoplasty balloon. If it is superficial calcium, go with the rotational or orbital atherectomy. And if it is not a significant calcium, then probably just a scoring balloon or a cutting balloon and optimal balloon expansion. At this point of time, sometimes you may be fooled, and if you want to repeat another intravascular ultrasound to make sure that you get a good luminal area, that may not be bad at all, and look for stent or calcium fractures before placing a stent. And if balloon does not cross, then I think, straight away going with the rotational atherectomy is not, or orbital atherectomy followed by lithoplasty balloon is not a bad option at all. So intravascular ultrasound or an OCT, both of them are very important to look at stent under expansion and stent malapposition. And after that, you can still post dilate with the non-compliant or OPN, super high pressure balloon, and or a lithoplasty balloon. When it comes to atherectomy, there are two devices that I think are also currently available in Pakistan as well, rotational and orbital atherectomy. Rotational is a unidirectional, whereas orbital, as you can see, it is circulating as an orbit, and it can get a much better, larger area with a single burr. But the expense of that limits my usage as well, and I still actually preferentially use rotational atherectomy at our center. So let's come to the tips and tricks, and if time permits, I'll show a case. Good guide catheter support is number one. If you need to use the Guidezilla or any other telescope type of guideliners, you can still use that. Radial or femoral access is not as important as catheter support itself, and achieving the best result is more important. And guide wires, I think you can always start with a simple guide wire. I'd like to actually put in a over-the-wire balloon and cross the lesion with a over-the-wire balloon and a regular wire, workhorse wire, and then exchange it to either any rotational atherectomy wire if need be. Otherwise, if the over-the-wire balloon goes in, and you can easily pre-dilate that, and then maybe you can follow with a non-compliant balloon, and in case if you do not want to do rotational atherectomy after an IVUS assessment. Using two wires in bifurcations and left mains is still possible whenever you use a shockwave type of lithoplasty. But when you want to use rotational atherectomy or orbital atherectomy, it is recommended not to place the wire in the circumflex if you want to do atherectomy in the ostial LAD. What you can do instead is maybe place a guide liner or a telescope, and you can get away without having a wire in the circumflex that can be traumatized or cut with the rotational atherectomy. So using IVUS or OCT or FFR in complex coronary artery disease, a complementary technology. I think not using these technologies is probably limiting us to understand about what we should do and how we should do in these type of calcified lesions. So the most important tip is prepare the lesion by whatever means, in the sense that I meant people might say, I'll do a compliant balloon or non-compliant balloon, then might say cutting balloon or rotational atherectomy. Doesn't matter. Whatever you want to use as per your comfort, use it, but prepare the lesion properly and adequately. Just because you think that a balloon passed, and at least look at it in two different views, and maybe a cine is recommended as well to understand if the balloon has expanded well in two oblique views. If you have a doubt, then actually better to cine than take much better pictures. If you don't have a doubt, and if it is still very having a severe waste, go with the atherectomy in those patients. So tip 4 is whether to use mechanical circulatory support in these complex high-risk patients. It is especially recommended in people with complex left main and bifurcations, where we are still studying whether Impella has any role in Protect 4. So we will probably learn about that in the future. So in short, tips and tricks of good guide catheter support, guide wire selection, imaging, and a rotational atherectomy to prepare the lesion, and hemodynamic support in sicker patients. So let me see if I can quickly show one or two cases. 70-year-old male with status post bypass surgery presented with non-STEMI. He has patent grafts and found to have a 99% proximal RCA. So this is a very heavily calcified, what we call as a calcified nodule. This cannot be stented without the predilation and even without atherectomy, in my opinion. So if you try to stent this one without atherectomy, you will be sadly surprised that there is a very minimal stent expansion. So here we were able to cross the lesion. I'm not showing you all those with the microcatheter help and a routine workhorse wire, then exchange it with the rotor floppy wire, and then a slow advancement. And then we were able to use a Wolverine balloon to expand that. And then, as you can see, the final result is excellent after placing a stent. So this is the pre and post. So this can only be achieved with preparing the lesion well. We used rotational atherectomy followed by a cutting balloon. So even in acute MIs, the calcified nodules present in about 8% of the patients. So diagnosing calcified nodules is very important. As you can see here, this is a patient with multiple calcified nodules, one at 11 o'clock and one at actually 6 o'clock as well. So the underlying calcium nodule, protruding nodular calcium with attached thrombus, and there'll still be superficial and substantial deep calcium. And those are the ones which are described as by OCT as calcified nodules. And these are the ones that will actually be a nightmare for all of us when we deal in the middle of the night. And this is a study that looked at the nodular calcium in group 1 and non-nodular calcium in group 2, and looking at OCT. And what it showed is that actually these calcified nodules can present in multiple ways. As I said, a single nodule, multiple nodules with superficial thrombus, or with adjacent dissection. And in this study, after looking at all these calcified nodules, will have smaller distal reference diameter. They have smaller minimal stent area. there's a lot more superficial calcium than we can understand, and a greater stent under expansion in these patients. And OCT score of 4 is more common in these people. So in such calcified nodules, addressing that further with the rotational atherectomy or orbital atherectomy, followed by either Wolverine or shockwave, is something that actually trials are ongoing and looking at it. So I'll skip that slide. As you can see, in rotational atherectomy, the need for a transvenous pacemaker is much higher than orbital atherectomy, but I do not think that we should shy away using rotational atherectomy just for that reason alone. So this is a slide that shows different type 1 to type 5 of calcified nodules, just a protruding calcium, but nothing on the other side. But there is also calcium on the other side, and there is a small dissection as well on the other side, multiple protruding nodules, and a protruding nodule with thrombus. So these can be diagnosed with the IVUS or OCT. And how do we treat is looked at whether rotational atherectomy has any role or
Ramesh, you have 30
not
seconds.
in a calcified lesions. And about 42 patients are matched in both the groups. And there is no true difference between rotational atherectomy or non-rotational atherectomy in the treatment of calcified nodules.
Ramesh,
But
you
that
have
said-
about 30 seconds if you don't mind.
Yeah, I'm almost done. That said, that you get better results with the rotational atherectomy followed by post-cutting balloon than with the conventional balloon. So my take-home message is select patients based on imaging, get comfortable with simple calcified lesions, prevent complications with proper technique, and rota followed by cutting balloon probably helps acute luminal gain, and do not rush in your procedures. Okay, thank you.
Thank you very much, Dr. Ramesh, for a very comprehensive talk. I would request Dr. Jabbar and Dr. Mohsin to please take seats on the podium. Dr. Mohsin Saif and Dr. Jabbar Ali. Thank you. So now I would call upon Dr. Hassan Sohail for his case in the treatment dilemma, pearls and pitfalls of treating a calcified lesion.
I would like to welcome my friend Dr. Rajiv Johar and Javed from UK. Fahim has been there since morning. I can't thank you enough. And Afsar also. And thank you, Ramesh. It was a great talk.
जी Assalamu alaikum and good afternoon to all. I'm Dr. Hassan Sohail, an interventional cardiology fellow at the Heart Institute, and I'll be presenting this interesting case of an undilatable lesion. Our patient was a 71-year-old gentleman who was hypertensive, having had coronary artery bypass grafting in 2006 with an internal memory graft to the LAD and saphenous venous grafts to the obtuse marginal and right-sided PDA. He was having CCS2 symptoms. His ejection fraction was 55% on an echocardiogram without any major valvular abnormalities. So we started off with adjusting his medication and a myocardial perfusion scan. The scan showed inducible ischemia in the LAD territory with high-risk features of stress-induced EF reduction as well as transient ischemic dilation. In view of persistent symptoms, despite being on maximally tolerated guideline-directed therapy and a high-risk scan, we took the patient to the cath lab. His angiogram revealed a moderate proximal left circumflex disease, and there was a tight osteoproximal calcified LAD disease. The right coronary artery was occluded totally in its distal course. The saphenous venous graft to the obtuse marginal were patent, giving off collaterals to a diagonal branch as well. The right-sided graft was also patent with some disease, mild disease around the insertion area, but with good flow. The internal memory graft, however, showed branches coming off its proximal course, leading to some steel phenomena, and there was competitive flow there. There's no flow into the distal LAD post its insertion. So keeping the clinical picture in mind, the scan, the symptoms, our plan was to do a left main to LED PCI. Since the lesion was calcified, we after wiring with the workhorse wire, we started dilating with a non-compliant 3,518 balloon, went up to 18 ATMs. But as can be clearly seen, there's indentation when the balloon is inflated. We were not able to successfully dilate it. We then moved on to the scoring balloon. The 3O15 scoring balloon was taken. We went up to higher pressures, up to 24 ATMs, but still were unsuccessful in dilating this hard calcified lesion. The obvious next choice was to do rotational atherectomy, and we did it with a 1.5 millimeter burr. The result, however, was not optimal. We could not achieve lumen Gale we wanted, and so we thought that rotational atherectomy had modified the calcium to an extent, and maybe a non-compliant balloon dilation at high pressure again would yield the lesion. But what we found out was that it wasn't the case, and we then again used a scoring balloon at higher pressures, about 24 to 26 ATM, after using this rotational atherectomy, but were unable to dilate this lesion.
So what size of burr was that, doctor?
1.5 millimeters.
Okay, so any options if the 1.5, after 1.5, the balloon doesn't expand? Clearly, it's deep calcium, which ordinary people would say, let's have an IVL, which you don't have, maybe a larger burr. So what are the options? Any comments from the audience?
From the online people?
There's some wonderful people online. Dr. Raza, Fahim Jaffrey, the usual suspects are all sitting there.
I mean, Sohail, the options would be to either IVL, if you have it, as you said, you don't have it. The other option is dilate with a smaller balloon at much higher pressure, like take an OPN that's slightly undersized, but go very high pressure. Third option would be to upsize the burr, and that's not a bad option, actually, in this kind of situation. So those would be some of the things you would look at.
What about the laser? We have laser here. Does it apply to this situation?
Yeah, I don't think so. So this is Ramesh again. So the option, there are several options. One of the things which is most important to remember is stenting is not an option. Do not stent it. I don't care whether you put another cutting balloon, laser, whatever you want to do, but I don't think you should never put a stent. And laser does not work much in these calcified lesions, in my opinion. We have used it all. And I know it has come recently to India and maybe Pakistan, and a lot of interest. I would actually go with a larger burr, and be careful with also OPN in these situations, because you can really have a perforation right after a road.
It'd be nice to know, obviously imaging is important here, but if you can't, is there a nodule present? Is there deep calcium, superficial calcium? I think the options are larger burr is probably the only option that I can think of. If you had orbital atherectomy that in Pakistan, that would be an option, but I don't think you have it right now. Laser, people talk about laser bomb all the time. I've done laser bomb, but only in stented patients where I can't dilate a restenosis. But the risk of perforation is tremendously high. When you do laser bomb with contrast, you're creating about 100 atmospheres of pressure, and the risk of perforation is very, very high.
So would you suspect that to leave this vessel alone if there's danger of perforation?
We have, in fact, done quite a number of cases, both in de novo lesions as well as in stent restenosis. I think if you carefully perform laser, the chances of perforation is very, very small, because in the majority of the cases, you do not have to cross the lesion, you just have to modify the lesion. And in this particular case, I do not think the laser is going to be that helpful. And I would actually upsize the burr, and using a bigger burr would actually create a bigger lumen because of the differential cutting. And after using a bigger size burr, then subsequently a non-compliant balloon, and maybe cutting balloon. Those are the options which are left in this case. In the ideal circumstances, IVL would have been very, very good in this situation, and IVL would have induced some not only superficial cracks, some deep cracks, and that would have resulted in adequate lesion preparation and modification.
But I think the most important point here is that do not stent. Do not stent under any circumstance.
That's a good point. Unless you dilate it, one must never stent it.
Yeah, I think you should keep in mind our limitations in Pakistan. We don't have IVL. Opening a new burr is going to cost over 100,000 again, from 1.5 to 1.75. And obviously, when you open any new thing, you have to keep in mind that patient has to pay, and how you're going to tell them like you have to pay extra 100,000, they will think that we did something wrong. So we had to choose something.
Bashir, I strongly feel that when we have a discussion like this, we should not probably think of Pakistani restrictions, because then we stop the discussion.
I fully agree. We need to discuss that. But what I'm saying is that practically when you're doing, we have, because a lot of us in cath labs may not even have a rotablator.
Yeah, of course.
We don't have IVL. So we have to think those things which in our limited resources, what we can do. So that's
what we sometimes do,
something that Paul has done, who's in the panel. He's taken 2 balloons and dilated a lesion like this and successfully got it open. I'm wondering if, Paul, you can shed light on that.
Yeah, thanks for mentioning it. And sometimes you just need to change the force to expand it. So sometimes you putting 2 small balloons and you use IVUS to gauge the size of the vessels. Sometimes 2 high pressure balloons, changing the force factor sometimes help. The other thing that I thought I sometimes would try to do, if there happens to be a branch coming off it, is to direct the rotor wire in a different branch, and therefore the same burr, same size, if it's possible to change the direction, so your wire bias in a different direction. Sometimes you modify the plug in a slightly different way, and it may yield.
Yeah, the other option you have is to put another wire down, maybe putting two or 3 wires down, and then almost creating your own angiosculpt type of balloon. And then ballooning with those 2 or 3 wires down, as a sort of a poor man's angiosculpt is an option.
This is something which we do quite often, where we put parallel wires down the artery, and then you give a prolonged inflation. You stay up. If the patient becomes ischemic, you bring it down and you take it up again. So prolonged inflation with a couple of parallel wires that can act like a. The reason we don't use compliant balloons here, because they'll dog bone around this lesion. But the NC will also dog bone if you give high enough. So that's a very great idea of having parallel wires. Any comments that we can ask the gentleman, Doctor? Yeah, of course.
So, just one more, just a small comment. For Bashir, when you have such a situation in Pakistan, you can use only 1 burr. The studies are now ongoing to see if you can reduce the RPM rather than increasing it, or larger burr. Maybe reducing the RPM, spending a little bit longer time, might be able to get away with preparing the lesion.
Just making a quick comment.
Sorry.
We in our cath lab would sort of take an OP and NC balloon and go with very high pressures in such a situation. So now we'll see what he did, Dr. Hassan did.
So obviously IVL, as discussed by the panelists, would have been ideal here, but since we don't have it in Pakistan, what we did was that I think Dr. Johar alluded to, we put in a parallel wire and we used an angiosculpt balloon, a 356 balloon. We went up to high pressures, up to 24 ATMs, hoping that finally this lesion would heal, since we had a parallel wire, would cause a cutting effect, that nitinol ring around the angiosculpt would help, but unfortunately it didn't happen. So the last thing we had in our armamentarium, as discussed, was a high pressure OPN balloon. And we used a 3O10 balloon, went up to 35 ATMs, and luckily we were successful in dilating this lesion. The next steps were routine PCI. We did a 3522 drug eluting stent from the left main to LAD, post-dilated, it with a 408 NC up to 22 ATMs, and this was our final result.
That was very nicely done. So OPN balloon is a real good option, but the cost again, like Bashir, we keep on talking about, this is sky high. But so parallel wires and staying up longer. But the real, I think the suggestion was to change the wire bias so it can shave a particular part of the calcium portion. I'll go to a lower speed also. That might help. So you can try those things.
Actually, all these things, parallel wires, we stayed even for a minute till patient has symptoms, even longer than a minute, multiple times, but nothing really worked. So that was.
Bashir, I've stayed up to 20 minutes intermittently, and that's when it came down.
Okay.
Yeah. So you need. Otherwise, the other choice is to give up.
Yeah. But luckily, we were lucky that our OPN worked, so everything.
Yeah, OPN is something certainly to be on board with us nowadays.
Sure. Okay.
So
I think the key thing about OPN is to be undersized and just go very high pressure. Then your likelihood of perforation is much lower. It's just if you go 1-to-1, then you are more likely to perforate at 40 atmospheres.
Absolutely.
Another thing which Jaffrey Saab said was to put two balloons, parallel balloons. Now, when you do put two balloons smaller size, you give asymmetrical expansion and forces. So that probably improves the chance of the calcific plaque cracking, rather than just one uniform expansion with a single balloon. Just some thoughts which
I think for future, when IVL is available in Pakistan, what we have found, in fact, IVL is going to be the best strategy in terms of calcific left main stem stenosis. And we just have published, in fact, it is in press, is going to be out next week, that we compared left main stem rotational atherectomy unprotected with IVL. There are over 100 patients in each cohort, and there was no difference in terms of mortality, in terms of short-term outcomes, but the lesion success rate was considerably high.
Thank you very much, Dr. Javed. I'll have to interrupt you here in the interest of time. Sorry for that.
Important in IVL arm, and it was easy to use technology compared to rotational atherectomy in the left main stem.
Thank you very much, Dr. Javed. Now I would request Dr. Robert Pio, Director Cath Lab, University Medical Center, Stony Brook, New York, to give his talk on prevention and treatment of no reflow.
Hey, good morning, everyone. Give me a second for me to share my screen. Okay, just going to do a sort of a audio-visual check here. I'm logging in from New York.
Dr. Pio, can you turn on your camera? Oh, okay.
Okay, I will in a second. Okay.
I guess we had seen your slides before, Robert.
Okay.
Right now we see them.
Oh, is this good? I was trying to turn on my camera here. I'm a little bit unaccustomed to Zoom, but in the interest of time, I'll start right now. Again, good morning, everyone. And I guess that's sort of in the afternoon over there. It's morning in New York, and it's a privilege for me to join everybody here. I'm from Stony Brook University Hospital, and I'm going to be talking to you a little bit about the slow flow or no flow phenomena after PCI prevention and treatment. Here are my disclosures. So this is a problem that many of us probably encountered. In the panel on the left, the patient presented with an MI, and in this case, it was caused by a proximal left anterior descending artery lesion. And the culprit vessel is treated successfully, but the patient does not do well, as you can see on the panel right. This is an example of slow flow after PCI, and in the worst case, there may be a cessation of flow altogether that may result in catastrophic hemodynamic collapse and even death. So slow flow and no flow refers to impaired epicardial coronary flow and myocardial perfusion despite patency of the epicardial arteries during PCI, and this results from impaired runoff of flow in the large epicardial arteries or the macrocirculation into the microcirculation, as can be seen here on the right. Now, no reflow is associated with even a worse prognosis than slow flow, and has been shown to be an independent predictor of death, MI, and impaired left ventricular function. All right, the impaired runoff into the microcirculation is caused by athero and thromboemboli and activation of platelets and subsequent aggregation here. Ischemia reperfusion injury further aggravates the process by causing vasospasm and in situ thrombosis. And the severity of the slow flow and no flow, as shown on the right side of the slide, is quantified in various ways, such as TIMI flow grade, TIMI frame count, as well as myocardial blush grade. Now, all of these grading systems evaluate the speed of runoff of the epicardial contrast into the microcirculation. Now, generally speaking, the prevalence of no flow in all PCIs is sort of low at 0.6% to 2%, depending upon what studies that you look at. However, there are certain types of PCIs where the prevalence is much higher, such as, for example, PCI in a saphenous vein graft or using rotational atherectomy, where the incidence can reach double digits. Now, medication is one of the mainstays of treating slow flow and no flow, and the major types of medications, as can be seen on this slide, consists of medications that cause vasodilations, GP2B3A inhibitors, as well as fibrinolytics. And we'll be talking about some of these medications later on in the talk. First, there's been a lot of studies suggesting that nitroprusside reduces the incidence of angiographic no flow during primary PCI, as can be seen by this slide. And in one of the studies that looked at nitroprusside, such as the reopen acute MI trial, adenosine improved microvascular obstruction in STEMI patients treated with PCI and thrombus aspiration. There was a greater incidence of complete ST segment resolution. Angiographic presence of microvascular obstruction was reduced, and the combined evidence of angiographic ECG as well as angiographic evidence of microvascular obstruction was reduced in patients treated with nitroprusside. Also, adenosine improved microvascular obstruction in STEMI patients in the reopen acute MI trial treated with PCI and also thrombus aspiration. And it seems like that adenosine improved outcomes in all categories of patients, male or females, whether they're diabetic, and in patients who arrived early versus late in the course of their acute MI. However, treatment with neither adenosine nor nitroprusside was associated with improved outcomes, as can be seen by this slide. It's important to note, however, that in this study that patients, the number of patients that were included in this study were rather low. And however, there were some questions to be asked whether if the study was larger, where there may not have been a difference. Now, however, going on with this study, high-dose intracoronary adenosine or nitroprusside did not reduce infarct size either, or microvascular obstruction as measured by cardiac MR imaging. Well, some of the beta-adrenergics, such as epinephrine, can dilate the vessels and may be one of the medications that can be used in slow flow and no flow. So as can be seen on the panel left here, this is a pig model of isolated arterioles, and low-dose epinephrine can vasodilate epicardial as well as endocardial vessels, as can be seen here. In panel A, isoproterenol, and in panel B, a selective beta-2 agonist vasodilates epicardial and endocardial arterioles in a dose-dependent fashion in a porcine model, experimental model. And they seem to open the arterioles through opening of ATP-dependent potassium channels. Now, if you look at the panel on the right, some of these principles seem to be applicable to human patients, and you can see that the application of epinephrine intracoronary improved TIMI frame counts in patients arriving with acute MI and undergoing PCI. Now, in the Admiral trial that looked at the role of GP2B3A inhibitors, epsiximab reduced the composite of death, reinfarction, and urgent TVR, and this was associated with a greater frequency of grade 3 coronary flow after primary PCI. And you can see that there was a difference at 30 days as opposed to placebo, and this beneficial effect of epsiximab seemed to be extended to 6 months after the PCI. Intracoronary streptokinase has given immediately after primary PCI also seems to limit infarct size after PCI. Now, the prevention of slow flow and no flow, I think, is just as important as treating no flow and slow flow in specific types of PCI. And one of these specific types is SVG PCI. And in this case, the use of a distal embolic protection device appears to decrease MACE as compared to control, as seen on the panel on the left, but there was no difference with respect to the specific types of device used. Additionally, pretreatment with vasodilators, as shown on the panel on the right, either 200 micrograms of rapamyl, for example, or 200 to 300 micrograms of nicardipine, may prevent slow flow and no flow, or at least reduce the incidence of it when you're doing an intervention in this type of vessel. Okay, the mechanism of slow flow and no flow in rotational atherectomy appeared to be secondary to embolization as well as a platelet activation. And the prevention of it is really dependent upon strict attention to good technique. And I think that some of these techniques may have been talked about perhaps in the meeting, but these include atherectomy speeds less than 150,000 rotations per minute, sizing the burr so that the burr to artery ratio is less than 0.6. You should limit short runs, the runs to 20 to 30 seconds. And what this does, I think, is it allows the distal vasculature to absorb the debris, if you will. And this is especially important in patients who have diffuse lesions with a large plaque burden. Rotational atherectomy solutions, or the Rota flushes, usually contain variable nitrates and even heparin. And it is thought that some of these components in the solution helps to reduce slow flow and no flow during rotational atherectomy.
Robert, you have 1 minute left.
Yes. So in summary, no reflow is associated with increased mortality and increase in infarct size. And these are recommendation of PCI recommendations in 2011. And it gives a 2A indication for treating some of these vasodilators. You must focus on addressing epicardial regions for TIMI flow first, then consider using the vasoactive and antithrombotic agents. Larger trials, however, are needed to show that there is actually a clinical benefit. You may consider thrombectomy catheters for a large clot burden, and in certain types of PCI, such as SVGs or rotational atherectomy, optimal techniques are important for prevention. thank you for this opportunity to present.
Thank you very much, Dr. Robert. Now I would request Dr. Tahir Shah and Dr. Asif Nadeem to please come on the podium. Dr. Tahir Shah and Dr. Asif Nadeem. Thank you.